Welcome back to the Skills Lab. Today we're going to be talking about Push Dose Epi. This is a new thing for our protocols. We're going to go through its administration procedure and when we're going to be using it. So Push Dose Epi is a lower concentration of Epi than what we traditionally give in like a cardiac dose, which is 1 milligram and 10 mLs, or the 1-to-1, which we can give intramuscular 1 milligram per ml. This is 10 micrograms per ml, or Epi 1 to 100,000. So this is a lot safer for IV use, and we're going to be using this as a short-term temporary pressure to transition you to an infusion or during periods of hypotension, like anticipated hypotension during an RSI. Let's say you have somebody that meets borderline or meets blood pressure criteria for a safe RSI, but we anticipate due to their clinical condition, or we've had to work really hard to get their blood pressure up, we anticipate their blood pressure dropping during that RSI, RSA procedure, and we don't want that to happen because we know that it leads to poor outcomes. We're going to be utilizing Push Dose Epi in those kind of cases to kind of bridge the patient over during that anticipated short-term hypotension, or if we recognize hypotension and bradycardia in the house and we want to move that patient outside, but we're concerned about their stability in the meantime. This is going to be a lot faster and safer option. It's also providing less volume. So in a patient that doesn't really necessarily need a lot of volume, this is not replacing IV fluids. Of course, if the patient needs fluid and volume, that's definitely still clinically appropriate. But if you need something, maybe not a ton of volume in a patient, as opposed to what we used to be using with a dirty epi drip. A dirty epi drip was 1 microgram per milliliter, because we put 1 milligram into a liter bag. And that patient received volume and infusion, which worked, but if that epi didn't dissociate or diffuse all the way through that fluid, there could be pockets with stronger amounts of concentration and of medication in different areas, and the patient had to receive all of that volume to receive the vasopressor. Push Dose Epi is a little bit smaller, and it allows us to give a little more precise, controlled, safe dose to know exactly how much medication we're giving to the patient, as opposed to they received X number of mLs of fluid. So we're going to be packaging them likely in some kind of vacuum sealed package very similar to this. It'll have administration instructions and an expiration date whenever it gets packaged, with the earliest expiration. But it'll contain all of these types of supplies. So you'll get a Epi 1 to 10 vial, and it's abject. You'll get a flush, you'll get appropriate syringe label, and a syringe transfer device. So to mix this up, we're going to start by taking our flush and holding it vertically and kind of expelling our air. Make sure we can see our ml markings. We're going to push the plunger till it says 9 milliliters remaining and there's no air left in the plunger. And we're going to put that to keep our tip clean. Go ahead and secure that on our transfer device. Take our epinephrine, our Epi 1 and 10, and expel all the air out of that. Put those syringes together, and now we're going to push Epi in here down till the syringe and the flush reaches 10 milliliters. Now there are 10 micrograms per milliliter in this syringe. Obviously there's a medication added. Anytime we add a medication to a syringe, we want to make sure that, or a bag or anything, we want to make sure it's labeled. So we have a pre-cut label in here with your dosing instructions, what it is, and purple means that it's a vasopressor. So we're going to peel off our label here, and we're going to apply it to our syringe, being careful not to cover up our milliliter markings, because that's how we're going to dose everything out. And these are all pre-cut to the exact length of your flushes. Okay, so now we have a very clearly labeled Push Dose Epi syringe. So now our dose is going to be 5 to 20 micrograms, and if this is 10 micrograms per milliliter, that equates to half a ml or 2 mLs. You start to get more alpha-1 effects, so the vasoconstriction, after 20 micrograms of epinephrine. So if you have a 20 microgram per minute infusion of epinephrine, you're getting more stronger alpha-1 and the vasoconstrictive effects than you are the beta-1 and the beta-2 effects than with the epi. So kind of keep that in mind with your infusions as well. So if you're wanting more vasoconstriction, similar to Levophed, go with a higher dose. You're still going to get the beta 1, the contractility, the dromotropy, chronotropy, increasing your heart rate and contractility of the heart, but you're also going to be getting more of those alpha 1 effects. So maybe if you're a bradycardic patient, you're just trying to increase their rate up a little bit, maybe they're borderline but somewhat stable or not, regardless. Going with a lower dose of like 5 to 10 might be more appropriate. You can always give more, you always can't take it away. Epi is going to be lasting in the body around 3 to 5 minutes. That's our standard cardiac arrest timing. You can give this as needed, every 3 to 5 minutes, and depending on how much you give will depend on how much is left in the syringe. So obviously we have a whole syringe here. The nice thing about this is that previous protocols, especially in anaphylaxis, a IV dose was typically 0.1 milligrams of 1 in 10 epinephrine. So the lucky thing is, even if you accidentally push this entire syringe, you're still not exceeding that dose that we would give in anaphylaxis as an IV epinephrine dose, or in asthma or COPD. Those protocols have been changed to reflect, because push dose is obviously a little bit safer for the reasons that we specified earlier. But even if you accidentally push this entire syringe, it's not the end of the world, right? It's going to wear off. So what we're going to do is going to be more careful though, and monitor how much we're pushing the plunger, as opposed to drawing up the precise amount of medication. So we'll find our stopcock here and connect it, make sure we clamp off below so we don't push too much. And then I'm just going to watch this plunger. Let's say I want to give a 10 microgram dose. All I'm going to do is push in 1 ml and then let that flow, because you likely have fluids running at the same time. So now I've administered that epi. I can resecure it on my person. However I do that, keep your tips clean. And now we can move the patient, monitor their blood pressure, move them once they're stable, do whatever we need to do. And then if their blood pressure drops again, or in 3 to 5 minutes when we anticipate it dropping again, pull it out, and maybe we need to do a little bit higher dose this time. So let's do a 20 microgram dose. So we're at 9, I'm going to push down to 7. Okay. And then resecure, keep it clean, and we'll do it on, keep doing that. Again, the goal, the new protocol that just got added, the crashing medical patient, really emphasizes prevention of that sudden ambulance death syndrome. So the situations where we either recognize that they're critically ill, but we want to get to our space, the place where we feel safe in our truck, when what really needs to happen is we need to further assess that patient and recognize their criticality and resuscitate them some before we move them. Obviously, STEMI, stroke, trauma, time-sensitive emergencies where we can't fix their underlying problem, there's going to be some variation there, right? But if your STEMI patient has a heart rate of 30 and they're peri-arrest, we should probably fix that before we move them so they make it to a cath lab. Or if your patient is just dangerously sick in the house, before we move them and jostle them and potentially cause arrhythmias and fail to recognize how serious the situation is, fix the problem, resuscitate them before trying to move on to another point of therapy. And hopefully this is going to be an excellent tool in your toolbox to do so. Once you get to your truck with that bradycardic patient, obviously the standard of care is going to be an infusion of epinephrine infusion that's already in the protocol, 1 to 10 micrograms per minute. This is not designed to replace that. It's designed to transition you, bridge the patient from to make it easier for you to get them out of the house without having to have multiple IV bags and things like that, to transition them short term to that long-term best practice of care of an infusion. If you have any questions, comments, concerns, compliments, cuss words on this procedure or protocol, feel free to contact myself or Brenda, and hopefully you've read all the new protocols by now. Have a great day.